Okay, just check to make sure that the recording has begun. So let me get started then on my presentation. You know, I'm very struck by the issue of sort of what does a family caregiver mean? I do a lot of work with caregivers in a lot of variety of situations. I have some staff who refer to themselves as caregivers. But when we talk about a family caregiver, it usually means an adult family member or another individual who is an informal provider of in-home and community care to an older person or to a person actually of any age with Alzheimer's disease or related disorder with neurological or organic brain dysfunction. That clearly family caregivers can be providing care to other individuals as well. But here we're particularly focused upon those who are caring for someone with Alzheimer's disease or related disorder. I say usually that it means an adult family member, but I recognize that increasingly we also have some individuals who are providing care who are under 18, perhaps a grandchild or a great niece who's participating in this as well. But usually we're talking about an adult. So when we think then about caregivers of persons with intellectual and developmental disabilities and dementia, I think that there's, in all caregiving situations, there's a growing variety. But I think that when we think about this population in particular, we're generally talking about parents, siblings, other relatives, sometimes friends. What you don't often see that it's a spouse. What you don't often see is it's an adult daughter or a daughter-in-law or a son or a son-in-law. And that reflects that for many individuals with intellectual and developmental disabilities, but not all, but for many, those partnering and child relationships do not always exist. We are increasingly seeing grandparents caring for grandchildren with disabilities. And I did meet an individual recently, an individual with Down syndrome and dementia, and a great-grandparent was involved in care. This was an individual who was in her late 90s. And because of the earlier onset of dementia in people with Down syndrome, you often will find these multi-generational situations. We are also seeing two-generation elderly families, older parents or older siblings caring for an adult over 60 who has an intellectual disability and dementia. And we also find caregiving situations where people may be caring for their own older parents, as well as caring for their son or daughter or sibling with an intellectual and developmental disability. But what may be different from other caregiving groups that you work with and for whom your programs were designed is that this is a group often where caregiving may be of lifelong duration rather than something that happens in older age or after a particular incident in adulthood. And because it's a lifelong duration, and yet this is often an older population, both of caregivers and of the person themselves being cared for, when a dementia is involved, there's often a lot of mutual caregiving that has built up over many years. For this group of caregivers, there is often the concern that they may not outlive their family member with an intellectual and developmental disability. In work that I do with other caregiver populations, part of the work that I do with them is sort of thinking about what happens after the person being cared for dies or perhaps goes into a nursing home. Here, the caregiver may not outlive, and that adds an additional concern in caregiving. So they often, as part of that caregiving, must plan for the future of the person they're caring for. So many of us do planning for the future as we think about palliative and end-of-life care, but this may be for a much longer period that they must plan for the future. And there's also a greater likelihood, though not guaranteed, but a greater likelihood that there may be a clash between what the caregiver is seeking and what the care recipient desires and needs. we have worked very hard to offer people with intellectual disabilities much more choices in their lives. And for family caregiving situations, that has often led at different points in people's lives to differences in opinions about what is called for. And I think particularly as you think about someone with an intellectual disability and dementia and sort of what is best, that the family caregivers may have, again, sort of a different view and a more protective view. And the care recipient themselves, particularly in the early stages of dementia, may still be seeking to live that more independent life that in many ways we have promised them through the services that we have provided throughout their lives. So again, as you think about the interventions that you have, think certainly about some of the differences that I've just described, but here's, some other issues and differences that I see. Certainly there are a lot of similarities. Many of the tasks are the same, and particularly the personal care tasks that I list here are likely to advance as the dementia advances, just as is true in the general population with dementia as well. But perhaps the family, for example, has always managed the finances, or has always provided some assistance, for example, with dressing. But again, sort of many of the tasks are similar. Some of the things that I see in the work that I've done in the families that I've worked with and talked with is that it is more likely that the caregiver of a person with an intellectual and developmental disability identifies as being a caregiver. I always remember two sisters who were caring for their mother, and I asked about caregiving, and they gave me this blank stare because they didn't understand what I meant. They were just supporting their mother. Whereas when I talk with a parent of someone with Down syndrome and dementia who has cared for this person since they were born, that's their identity. That's who they are. They're a caregiver. It's likely to have been lifelong. They're more likely to have had to supervise all activities for a very extended period. As I said earlier, it's unlikely that it's an adult daughter or a daughter-in-law where, and then sort of think about the groups who come to your interventions when you are offering a caregiving intervention to a broader group, is that adult daughters and daughters-in-law are likely to be well represented in those groups. They'll be absent here. The person is more likely to be a sibling than we see with other groups, a sibling of the person being cared for. And the person cared for is less likely to have had a previous independent life. So some of the issues that are being presented are very different because of that. But I think one of the biggest differences in the experiences is that, again, I talked about sort of the promise that we have given to people with intellectual and developmental disabilities, that their lives will become progressively more independent. And that independence has been experienced by their family caregivers. But the other thing that those family caregivers have experienced is that over the lifetime, they've figured it out. They've been very successful caregivers many times, and suddenly the things that always worked, largely because of the advance of dementia, don't work anymore. And a caregiver who was previously confident in their caregiving loses confidence, experiences some of these things as even more stressful because they thought they had it under control, and now they don't know what to expect. And so I think that that's one of the important differences that people experience and present when they're talking in groups or in individual caregiver interventions. So just to give you some examples of these caregivers that perhaps helps you to anchor that in a particular way. A 92-year-old widow who lives and has lived with her 64-year-old son with intellectual and developmental disabilities in a rural community. They lived pretty independently for many years in that community. A grandmother in her 90s who is the sole source of support for her grandson aged 48. A recently retired 65-year-old widower caring for his own mother, who is also the primary caregiver for his 41-year-old son with Down syndrome and newly emerging symptoms of dementia. That widower could also be the primary caregiver for his 41-year-old daughter with Down syndrome. A woman, 72, who cares for her sister with intellectual and developmental disabilities, who is 67, and both are showing symptoms of dementia. I think particularly in that situation where a transition may have occurred from a parent to the sister of the person with an intellectual disability, in the belief that I'm passing on this responsibility to someone who's in a much better position to provide care. And what if that person then themselves experience symptoms of dementia? And I think that we have to think about dementia as being potentially present in a whole variety of caregivers as well in these kinds of situations, that it's not just the person with an intellectual or developmental disability. So we have a lot of traditional challenges and a lot of new challenges that are emerging for these families. And I raise these issues because I would hope that you would think about in your delivery of your interventions that these issues are likely to be different from what you've traditionally addressed, and what is important to other participants in the groups. Because many of these caregivers, when I talk to them, when they have sought support from traditional caregiving groups, talk to me about how so much different their issues are, and how, whether it's the leaders of the groups or the other participants, don't understand and perhaps don't want to discuss those issues to the level that they would like to discuss them, because they have other issues that they're really focusing in on. So first of all, in many ways, family caregivers of people with intellectual and developmental disabilities have access to a set of services through the intellectual disabilities system that other caregivers don't. Just a broader range of services that they can potentially access. But many of these families haven't accessed those services, have chosen not to access them, are not actually as familiar or very familiar with those services. But on the other side of that, many of the family caregivers talk about already receiving my services from the DD services system, but the services perhaps from aging support and Alzheimer's support organizations may be more appropriate, but they're concerned about accessing services from a different system because they're concerned that they could potentially lose access to those traditional intellectual and developmental disability supports. It's not necessarily that they will, but that they have a concern that they might. I talked earlier about the reality that the family member with a disability will outlive the person, simply because, chronologically, that presents as a great likelihood. It's not necessarily how people experience it. In some of the research that's been done, recall one researcher talking to me about a 95-year-old mother caring for her son with Down syndrome, and he said to her, "Well, what's going to happen when you're not here?" And she said, "Well, it's too soon to think about that." Some of this is about simply not thinking about it. Some of it is about, I just really can't think about it. But nevertheless, the reality is that this could happen. And the concern is that if you're not dealing with it, if you're not planning for it, then that change becomes very abrupt. And the abruption of losing the caregiver that you've traditionally relied upon, may often mean, for example, movement to living somewhere else. For a person with dementia, becomes even more disruptive. To recognize the strong interdependency between caregivers and their family members, that there's a very strong emotional aspect to this that probably matches and may even exceed the relationship between spouses. And then the inability of these caregivers, particularly as they're getting older, to reflect on their own aging and to plan for themselves. So I've talked a little bit already about planning for the person they care for, but they have their entire lives put this person first, this son or daughter that they care for. And they don't reflect on their own. They still think that they, or want to think that they can do these things for themselves, and they don't plan for their own aging necessarily. And then, even though there are services that, many of our services are organized in a way in which we tell people what they need and we meet that need. But these are families, and particularly when the service is targeted at the person with an intellectual disability, or the service is targeted at the older person as a caregiver, there's not always good coordination between the services and what they see as their needs as families. And in your interventions, people will often be asking for help around negotiating that lack of coordination. They may come across at times as, I don't want to say ungrateful, but not appreciative perhaps of sort of the services that are available. And their response is, yeah, but these aren't the services that I need. You've decided that these are what I need. How do I talk to my case managers? I remember one caregiver, and I asked her, well, what do you think you need? And she said, I need a case manager for my case managers. Because people were offering her services, but they weren't what she wanted. And also because they were contradicting each other, and she needed somebody to manage. She said, this is just more work rather than real help. And other families that I've talked with, would say to me that they would love to have that situation, that they're overwhelmed with services, but sometimes being overwhelmed is exactly that. It's being overwhelmed. Those additional services are not actually being helpful. So what are the needs of these family caregivers? There's a huge need in the area of assessment, diagnosis, and care planning. The strategies that you have in working with other caregivers, the resources that you make available to them, are not necessarily going to be helpful to these families. Most of the assessment instruments that we use for the general population aren't adequate for people with an intellectual or developmental disability. Most of the people that we will refer you to don't usually work with people with intellectual and developmental disabilities. Most of the planning, the case management kinds of services aren't exactly the same as what these individuals will want. I think respite, housekeeping, transportation, those are things that we often see in common. Financial supports and determination of eligibility, we do some of that with all families, but there's a particular level of issues for these individuals. The understanding of financial planning, that there are plans that people are making, particularly around money, that may actually deprive their son or daughter of services that they need if they're not carried out in the appropriate way. And so that one of the things that people will often talk about as caregivers of an individual with an intellectual or developmental disability is that they need help negotiating the various service systems. They need help in understanding what services are available and how to receive those services. And in particular, they need help around understanding access to Medicaid, what's available under Medicaid, what potentially places their Medicaid eligibility in jeopardy. And often that many of these services, there's a lot of paperwork associated with them, and concerns that arise, and they need help around resolving those problems. They also need help with making future life decisions. This is something that for this group of caregivers, there is both the issue that I'm not planning for what's going to happen if I'm not here. But then equally, if I decide I want to plan, well, how do I do that? Who will I talk to? How do I have that conversation with other family members, like a son or a daughter, to assume this responsibility? We do a lot of work through caregiving interventions around helping people plan for the future in terms of palliative and end-of-life decisions and living wills and things like that. Those things are relevant for people with an intellectual or developmental disability. They are more difficult to ascertain in terms of what people's future wishes are. People need additional help in establishing those instruments and understanding what they mean, particularly when you may have family members who still think that they actually are the guardian, they actually are the decision maker for their son or daughter, but they've never gone through a process of establishing formal guardianship. And so, again, these are issues that are less likely to come up with other family caregivers. So one of the other things that I think about, and often families talk to me about, is that the most needy are actually often reluctant to seek help. They've managed really well for very many years. This is a lifelong caregiving situation. Yes, things have changed. Yes, the things that worked for me in the past are not working anymore. But part of managing well for all those years is that you manage independently. You rely upon yourself. And now that things are not working well, you're telling me that I have to let other people into our lives and be part of making those decisions. And some people struggle with that. They worry in particular that those coming in will make a decision that they're not able to provide care and that their family member will be taken away. They may not express that in words, but that's what they're thinking. They're also, again, because perhaps they are starting to think about that they may not be there for the rest of the person's life, are there actually any services they can rely on? And I often think they have reason to be concerned, because we have changed the service system so many times over the last 50 years that people are concerned about, well, you're saying to me that this will be the service that will meet the needs of my family member. How can I be sure that that service will be there? How can I be sure that my family member will always be eligible? Some may have had past negative experiences working with the disability service system. Many report that they find working with agencies complex and impersonal. And so again, sort of they're reluctant to get engaged with systems that actually can be very helpful to them. And so as we think about how we work with families, how we actually help families, it is about thinking about how do we help people with these concerns. I train social workers, and when I talk to students who are working in this field, they talk to me about, many of them are in their 20s, and they say to me, but I didn't do that 40 years ago to this family. Why are they so mad at me? And what I often say to students is because you're the first person they got to be mad at. And also because they're feeling now like they're not going to be able to manage this for themselves. On the one hand, they need your help, but on the other hand, they're still mad about things that happened in the past. And you're the person who, yes, I agree, may not feel fair that you're the person taking the brunt of this, but you're actually the person, and probably the first person, who has the ability to change this, to actually help people to be successful. So I think about the same thing, that sort of within groups or other caregiver interventions, that you're going to have people who are resistant, people who are even a little bit annoyed about what's going on, and who will be seeming to blame you for some of these things that have happened. But you're actually the opportunity to provide help. And so how are you going to negotiate that and get past these issues, or help people get past these issues so that they can receive the help that they need, so that they will be successful in continuing to care? So I had the opportunity to interview a number of family caregivers of people with Down syndrome, and I'll talk about the unique role of Down syndrome within intellectual disabilities and dementia. But I had the opportunity to interview a number of caregivers of persons with Down syndrome and dementia. And they talked to me about that they just didn't fit in traditional caregiving interventions. And so that caused me to think about, so why can't we fit these caregivers in? Some of you may recognize Mary Hogan, who's in this picture, and this is her brother. Mary has been very open about the story of caregiving for her brother, and is a great advocate for these families. And this was a piece that she gave me to utilize in presentations. She talks about, when my brother was experiencing a precipitous decline, I felt desperate as I searched for others who could relate to our experience. Without a connection, it was isolating, and I was groping in the dark to make sense of what was happening. I needed a voice that could relate to me and offer some affirmation. And I think that Mary really captures what a lot of these caregivers talk to me about, is that they feel very isolated, even when they connect with caregiving groups. And I asked them, I said, well, what happens? What makes you feel so isolated within the groups? And they talked to me about things that are not helpful. They said that when in the groups, people are using examples and talking about dementia, and they're talking about caring for people who are over age 70. All the discussion is 70s, 80s, and 90s. And for many of these family caregivers, particularly those who are caring for someone with Down syndrome, dementia is occurring when they're in their 40s, their 50s, and their 60s. Then in particular, they want a leader who's knowledgeable about dementia issues for people with Down syndrome. That sometimes the reason why they don't go to a group is they think to themselves, well, what if there's nobody there who's like me? And that they'll stick out like a sore thumb, that people actually may not even want them to be there because their situation is so different. But they also talk about what we do in our interventions, that they don't want to be educated. They don't want to be told how to caregive. The caregiving hasn't been, as one caregiver said to me, she said, it hasn't been a surprise for 50 years. And they understand that for other caregivers of people with dementia, that this is a new experience for them. You know, I think of family members who talk about, you know, my mother who had dementia, she always cared for all of us. This was the first time I had to be her caregiver. Well, that's not the experience of these caregivers. Caregiving hasn't been a surprise for 50 years. They talk about examples and discussions of ways to cope that aren't meaningful for their situation. And in particular, they talk about, and I think this is one of the toughest pieces for all of us leading interventions, is that they feel like everyone else gets helpful advice and everyone else gets to develop relationships in the group because there are other people who are experiencing similar things and have lived similar lives. Their lives are so different. Their experience is so different that there isn't someone else to relate to in the group. They don't feel that a lot of the advice is helpful for them. Now, there are some groups that are specifically targeted at people with intellectual and developmental disabilities and dementia. But this is not a very high incidence in terms of the sheer numbers nationally of people. And so it's very hard for those groups to form and there be enough people for it to be a group, that it's more likely that they're going to be asked to fit in, as I said earlier, to fit in to existing caregiving interventions. So I'm not saying that they can't fit in. I actually think there are great opportunities to include them. But if we're going to run interventions that include, then we have to pay attention to sort of the things that they're saying that make it very difficult for them to want to stay in the group. And in particular, a need for leaders of interventions, whether it's individual counseling or it's group interventions, or even sort of in terms of the provision of respite and other types of interventions, that they want to be able to talk to someone who's knowledgeable about dementia issues for people with intellectual and developmental disabilities, particularly people with Down syndrome. And so it becomes something, it becomes another thing to add to what we need to know to be effective leaders of these kinds of interventions. More specifically, they talk to me about the credibility of the people who are telling them that they can help them. And as, again, one mother said to me, she said, to be mildly hypocritical, when I'm overwhelmed, if someone who hasn't had that experience comes to me and tries to help me, I'd be like, you have no idea what you're talking about. And I've experienced that with other caregivers as well. And but I think that it's heightened when we don't really understand dementia among people with intellectual and developmental disabilities. It's heightened when we have no experience of working to support these families. And it means then that people are less likely to access the help and support that we're trying to offer. So then I think about the inclusion and sort of how do we become more effective in including these caregivers in our caregiving interventions. And again, I want to say that I think that there is great value in building that kind of inclusion. I think that we need, first of all, to understand intellectual and developmental disabilities and dementia. What happens for this population? What are the risk factors as compared to the general population? What are the ages of onset? Understanding sort of what are the changes that happen? What's the same? What's different? I've talked already about sort of understanding the differences in the caregivers, but also understanding the experience of dementia. To think about language, that we have worked very hard in this field to build a consciousness around people first language. And when we talk about disabled people rather than people with disabilities, when we see people as being always needy rather than also having their own strengths, when we talk to these families as sort of needing to be replaced because they clearly are overwhelmed, the language that we use makes a really big difference. As that mothers talked about, these are really, I'm always struck by this. These are really strong people. Now they're getting a little overwhelmed, or maybe a lot overwhelmed, but within themselves, they're really strong people, and our language needs to respect that strength. To be thinking about, is there content in what you're providing that speaks specifically to the issues of dementia in people with intellectual and developmental disabilities? And to think about examples that we're using. Will the examples be meaningful? In other work that I've done looking at evidence-based interventions, I've talked with, I remember once talking with a group of wheelchair users, and they talked to me about their concerns when they went to interventions. And they said, the minute you use an example that talks about people walking, I just want to leave, because I'm a person who uses a wheelchair and I can't relate to that. And I think the same thing here. If I'm a person caring for an individual with an intellectual and developmental disability and dementia, and that person is 60 years old, and you're talking to me about spouses caring for people in their 80s, it's not meaningful. Now, that doesn't mean to say that all the examples have to be relevant to me and my situation, but I think there's a need for a purposefulness of ensuring that in our language, in our examples, in our content, in our interventions, that we are saying things that I can see myself. I can see why this is relevant for me. And I can see you saying, I think your issues are important as well. So let's talk about dementia in people with intellectual and developmental disabilities. So this is a graph that we use a lot because I think it really captures the uniqueness for this group. There is a group of individuals who have an intellectual disability, who have a syndrome called Down syndrome. It's about a chromosomal disorder. And actually, interestingly, the chromosome is also linked to Alzheimer's disease. And so one of the things that we see with this group with Down syndrome is that Alzheimer's disease in particular, but dementia in general, tends to occur at an earlier age, and tends to touch a greater percentage of the population. Not everyone will show symptoms of dementia, but everyone will have the plaques and tangles, is how we often explain it to families. But when you look at the ages of onset, that between ages 50 and 59, 55% of people with Down syndrome will present with symptoms of dementia, 75% at 60 plus. Now, this is clearly something that happens much earlier ages for people with Down syndrome. For those with intellectual disabilities that are not Down syndrome, some people argue that the rates are similar to the general population, but the prevalence studies with large samples tend to argue that it's higher for this group, but the onset is likely to be at similar ages to the general population, but it's likely to occur higher. The real challenge, though, really is in assessment for these populations. That measures that we use for the general population, often people with not everyone, but often for many people with an intellectual and developmental disability, they'll score in the range of dementia already because of their existing disabilities. So how do you then sort of track changes? How do you then establish that someone has a dementia? So there are a series of specialized measures that have been developed. There are recommendations around really following people at very early ages so that we can see the change over time. So that, for example, for people with Down syndrome, that we probably should be measuring for dementia really starting at about age 35. Not because we expect it to show up at age 35, but we establish a baseline for them, and then we start to see the changes that are happening over time. And probably for people with other types of intellectual disabilities, we tend to encourage doing that probably from about age 50 on. Now, these are encouragements, they're not requirements under anybody's guidelines, but these are things that are strongly encouraged. So you see then that sort of this is occurring sooner, it's at higher rates. Some of the other things is that the initial decline is more rapid than we see in the general population, but it has an extended late stage. It used to be we thought that people with Down syndrome was more rapid decline and that they died much sooner, but we're seeing that the late stage is actually quite extended. So the discussions that we often have in caregiver interventions around stage-based needs, the stages look different for this population. As I said, a more rapid decline initially, a longer late stage. So that moderate stage where we tend to focus a lot of services for other groups with dementia may not be as, certainly may not last as long for this group, or may occur much sooner. The other thing, and this is particular to people with Down syndrome, is that what we're seeing is that there is co-occurring epilepsy. And one of the things that families talk about when they're interacting with caregiving programs is that people don't realize that the management of the epilepsy is as problematic as the management of the symptoms of dementia, the needs for services, the need for information. Families will say to me that if they approach a caregiving program and people don't act surprised that there's epilepsy, that's a clue to them that you don't know their population. And so then they're suspicious of your ability to provide support. The other thing that I always think about is that when you have existing disabilities and existing limitations in your ability to do activities of daily living or instrumental activities of daily living, relatively minor changes that may happen because of dementia can have a big impact on your level of independence, much bigger than would be true for the rest of the population. Changes can be quite dramatic in terms of independence from the perspective of the family caregiver. But for other people looking in, if you like, from the outside, it doesn't seem like much has changed for the person, but it makes a difference in what they can do. And again, when you think about the mutual caregiving that often goes on for this group. This is particularly challenging because this is where the emotional support that the family member with an intellectual disability who often provided to their caregiver, this is often the one that suffers the most in changes that are associated with dementia. And then the last piece is this idea of the broken promise, that we have told people with intellectual and developmental disabilities, and we have told their caregivers that all of the services that we're providing, it's not just about maintenance. This is about ensuring that people with an intellectual and developmental disability will be more independent this year than they were last year. And now we move into trying to maintain the independence that people have. And then for these families, watching the independence that they worked so long to help build decline and disappear. And so again, sort of these are the things that sort of we need to be thinking about and paying attention to. I think that when we think about quality of life for people with intellectual and developmental disabilities and Alzheimer's disease, much of this is similar to what we would hope for and be concerned about for everyone with dementia. Things like absence of pain, maintenance of health, psychosocial well-being, skills maintenance and support. But again, think about that in the context of a sort of a relatively small change will make a huge difference for the individual. One of the things that we work on very hard is getting people to move away from managing problem behaviors to avoiding problem behaviors. Because they become too hard to manage. So it's about sort of how do we take away the frustrations? How do we anticipate things that are going to present difficulties for the person and work on that? To be looking at sort of how we maintain leisure and community participation. I think this is a challenge again for everyone with a dementia, and similarly sort of contact with family and friends. But because the change can be a small change, has a dramatic impact on people's independence, a person's ability to participate, that it requires more work. And this may be where the family really is looking for help around sort of how do we maintain some of these activities that the person really enjoyed in the past. We need to be thinking about dementia-focused programming, that often there are day programs, but are they focused upon how we support dementia, that they may need help with supportive environments. Again, I think that applies for everyone with a dementia, but again, it's sort of very quickly a person with an intellectual and developmental disability can experience a dramatic loss of independence. Can we look more effectively at environmental modifications to try to maintain some of that independence? And because of the demands of the caregiving situation and the emotional impact of watching the person decline, who I worked so hard to build their independence, that we probably have an additional burden on caregivers that we need to be working on alleviating. So I'll talk a little bit more about language. To get to know terms like people first language, that I'm a person with a disability, I'm not a disabled person. To understand our desire around least restrictive environments, that sort of to place them least structures on the person, to have people live as normal a life as possible, that they are part of decision making, that we develop plans that really are centered on their needs and desires, and that we support aging in place. Too often, because we see a person who has a significant disability already, we may think much more about supports that replace what a person used to be able to do for themselves, including what a caregiver was able to do for themselves, and are not focused enough on maintaining this life that they have always lived. We need to get to know the services. There are residential options, but I think that sometimes we go too quickly to thinking about, well, maybe the person needs to move out. Families are not interested in that. There may also not be options available for the person. but get to know what those options are, to think about the day programming that's available. That varies a lot by state. There are some states that are very well developed day programs. There are other states that think that, you know, everybody should have a job and that there should not, that that's how they organize their services, and there aren't other options. To realize that employment has been a very important value for the person with an intellectual disability. In many ways, their self-worth is very much tied up in that, but it's also effectively been respite for the family, and employment may not be as supportive of an individual with an intellectual disability and dementia. To understand what respite needs, that these are 24-hour caregiving situations many times. So where's the targeting of the respite that really meets the needs that the family and the individual themselves are identifying? To be looking at the support of adaptive and communication devices. We've done a lot of work with people with intellectual and developmental disabilities when they're children around these adaptive devices. But now that they're older, perhaps experiencing symptoms of dementia, there's a whole new series of needs. Are there resources to support those needs? To be thinking about environmental modifications, as I said, and to be thinking about family education and training, to be training people around sort of understanding what dementia is going to mean. And as well as knowing the potential services that are out there, to know who provides them, how do you access them, that you're able to give good advice and good assistance. To understand that there is a dilemma in services for people with intellectual and developmental disabilities, that we need to be responsible for protecting citizens with disabilities, but not to unduly suppress choice and self-direction. So what does that mean when a person has this added piece of a dementia? How do we not sort of just completely give up what we have always known? So let me talk about some content that might be particularly relevant. Again, sort of as we think about sort of how we manage people through the transitions associated with the stages of dementia, to think about sort of what are the range of respite and other services. So you probably have respite services, but are those services able to support people with an intellectual and developmental disability? Again, to think about the environmental modifications. Do you have access to legal and guardianship supports? Because these issues are going to be larger for this population than perhaps for others. Similarly with financial planning, to dealing with Medicaid issues. One of the things that I'm very struck by is that when a dementia occurs, there are some families who've never really utilized services before, and now they need services. And part of the challenge for them is that they were never declared eligible for those services. So helping people around eligibility, to recognize that eligibility may only mean, therefore, that you're eligible to be on a waiting list rather than to receive the services. So getting people to think about establishing services sooner than they're ready to utilize them. And I find that very challenging myself when I'm working with families that they're not really ready, but I know they need to be ready, but you know, they're making the decisions, and I need to find ways to support that, but encourage them to at least look into the eligibility issues, to get their family member on a waiting list, so that when they do need that level of services, it'll be available to them. Thinking about ways in which we can support people to continue to attend whatever day programming options are available to them. To me, that is one of the principal caregiving supports that we have available, because that gives everyone a break, and it gives the person a connectedness to familiar people and familiar things. And then looking at sort of how we work with people to consider, if it becomes necessary, movement to out-of-home placement. I think that's something, again, that occurs with a lot of families, but it is a particularly value-laden process for people with intellectual and developmental disabilities. So then, in terms of planning to sort of think about the future life for both the person and the future life of the caregiver. To be one of the things that families talk a lot to me about is that once their family member with an intellectual and developmental disability gets a diagnosis of dementia, that everyone else, and healthcare in particular, thinks that that explains everything. They have this lifelong disability and they have dementia. That explains every symptom that they have. And instead, they still have comorbid health conditions. They still need to sort of eat a healthy diet. They still need to physical activity, and they still need to be able to access the health care that they need. And so planning for that, thinking about how they may access aging services as well. And then again, that sort of, if this is about an older caregiver situation where the caregiver is a parent, how do we begin to engage siblings? There's a lot of literature on this. There's a lot of experience with this. And older parents often are reluctant to involve siblings because they're afraid the siblings will say no in terms of providing help. They'll often say yes. So that this may require a lot of work in terms of helping them to sort of to explain what is the support that they need. And then again, sort of addressing the guardianship, legal, and financial issues. So then I think about finding meaningful participation and sort of how do we get people who are caregivers of persons with intellectual and developmental disabilities and dementia, how do we get them involved in our caregiving programs? Certainly a lot of it is about building the relationship, that we have to be careful about suspending our own judgments of the situation. We need to listen to the story and the history. This is what I was talking about earlier when I talk with students who are preparing to be social workers in this area. It's like, yeah, you need to listen. No, you weren't responsible for this, but you need to listen. You need to hear this. This story is what has kept this caregiving situation together. You need to acknowledge where service systems have not done well. We need to avoid jargon because they've dealt with jargon their entire lives and they don't respect us for it. You need to appreciate a lifetime of caregiving. These are incredible people. And you know, we should acknowledge that. And then, you know, I talked before about person first language, but we also have to be careful about what I call person first corrections, that I'm using the current language, I'm being correct about person first language, but often I will talk with a family member who uses older language, who's not particularly person first. If my first interaction with the family is to correct them, we're not building a relationship. So I won't allow outright disrespect, but I'll be sensitive to maybe that's something we can deal with as we move along. Or you know, I think one of the things that is always often raised to me is that a parent is still using a childhood name for a man who's 58 years old, and because that's what they have called him, because they have cared for him since he was born. You know, are we going to insist that he's James and not little Jimmy? What are we gaining by challenging people in that way? So I think that we need to, within particularly group interventions, that sort of finding new ways to address caregiving and behavioral challenges that are different, to have advice around managing epilepsy. You know, I'm not a physician either, so I don't get into prescribing or things like that, but I certainly try to connect people with resources or suggest to them, you know, how they might phrase some of this in terms of talking with their healthcare professional, so that they'll explain themselves better and be able to get the advice that they need. I place a lot of emphasis on self-care for the caregiver. This is a group that never takes care of themselves. And, you know, as we are often, you know, many times at the same time, because I don't want to make recommendations that are beyond my scope, and I say to someone, consult with your physician or your healthcare professional, I realize that many times that means for this group that they'll be left with no advice. And so I really want to sort of help them. So I try to give concrete advice or give them handouts that are from reputable sources so that they have some information. I'm still going to encourage them to talk to their physician or their healthcare professional, but I try to give them information that they can bring with them so that they can explain themselves better, because I am concerned that this group is often left with no advice. In terms of siblings, some of the things that I've done in group interventions is sort of help people practice the conversations with their sibling or the family meeting. To recognize that sort of, for example, in an intervention where we encourage people to do goal setting and, come back and report to the group, how did it go? I'm really prepared for that the conversation will not go well. And so I think about sort of, okay, so how will we respond? How will we support the person that they will keep trying and that they will feel supported? And in particular, sort of one of the things that I try to encourage people to do when they're talking to their siblings, instead of having the conversation about, I need you to take over care and to do this for the rest of this person's life, is, well, let's explore specific help that's needed. Let's break it down. What would be really helpful now? What would be really helpful in the future? And help caregivers who are looking, particularly parent caregivers who are looking to have their other sons and daughters assume some of this responsibility for this individual that they have cared for. Like, let's do it around specific help needs. Again, I think that some of the things that sort of we try to do is to help people for those health professional visits. That's scripting. I think we do that a lot increasingly for a lot of caregivers, but sort of helping them around the specific issues that they're interested in, helping people to understand what will be paid for, because that's often a fear that sort of things will not be paid for, and actually more will probably be paid for than people expect, because the vast majority of people with an intellectual or developmental disability qualify in their own right for Medicaid. And so understanding what, and I know that's not always, that can be a moving target in terms of what will be paid for, but understanding what will be paid for, helping people to access sources of that information. And then the other piece is that diagnosis is difficult in this population. There's a good likelihood of co-occurring conditions. So helping people to ask the right questions, to find individuals that can help them with differential assessment and to get a proper diagnosis. I still run into families who talk to me about that they never actually got a diagnosis. And it would be really helpful to have the diagnosis. Even though they're doing all the things that they need to do, they struggle with not knowing what this really is, not having it confirmed. I think that one of the most challenging pieces in dementia is preparing people for advanced disease. I think that's true for everyone involved. But I think that the advanced directive issues are different. I think that there are challenges in transfers to hospital, transfers to nursing homes, perhaps, that are experienced as particularly difficult by these families. And the whole issue around palliative care, when to initiate it, who's making the decisions, can we develop plans? Many people with an intellectual and developmental disability can develop plans, can tell us what they would like in their last days, what is too much, what's acceptable. But we need to have those conversations very early on. Again, I think that's true for everyone, but I think that we have to be particularly careful that not to make the assumptions that, well, that decision just can't happen with people with an intellectual or developmental disability. Many are able to. There are actually some really great materials on explaining dementia, on explaining death, on explaining palliative care for people with an intellectual developmental disability. There are great materials that explain it for the caregivers of those individuals as well. So we need to access and make available some of those materials too. As we look towards the future, sort of helping people to identify services that benefit both of them, discussing future plans, really looking for that involvement of other family members, identifying and problem solving barriers to planning, developing and implementing a plan, celebrating successes. These are things that many caregiving interventions do really well. But it's about seeing this as a population that will benefit from that, using the right language, using the right examples. So I would encourage people to sort of step back and think about, well, how do I present this? What are the examples that I use? How could I present this differently in a way that will engage and respect people and encourage them to participate? I think that that's the real challenge as we look at how we incorporate people who are caregiving for someone with an intellectual and developmental disability. So these are some resources that are available. One is a booklet that was developed through the National Alzheimer's and Dementia Resource Center on behalf of the Administration and Community Living. I'll provide these links as well. This is a toolkit for state and local aging agencies that has a lot of really good information. You can find the link for this in the NADRC booklet as well, but it's a specific toolkit that's focused on aiding older caregivers of persons with intellectual and developmental disabilities. And you can also email me. My email address is right there. This is a 2 CD-ROM set that I developed a very long time ago with assistance from one of the developmental disabilities planning councils. And it's still very relevant today, and it's free. I'll be happy to send it out. So, encourage you to think about sort of all of those things. And I suppose too, sort of want to say how much I appreciate the support that caregiving programs provide to a very important and often underappreciated resource in general, which is family caregivers. And so much of my work has been done with the family caregivers of people with an intellectual and developmental disability. And I think that they are a particularly heroic group. And I don't say that in a patronizing way. I say it I'm just always impressed. And so I think that that's what drives my desire, that we find ways to always encourage them and always find ways to support them in ways that are respectful of all the things that they have done over the years. So I'm going to finish up there. I will take questions. You'll see a button that says Q&A. And if you want to type in your questions there, we still have some time left. And I said that I would do this, make myself available for those questions. I'll try to answer them. And if there are any that I don't feel like I'm giving an adequate answer, I will send a written response back. So I'll pause for a moment and really encourage people to put their questions in. Okay, so all right, so I got a question about epilepsy, and I got a question about what's an example of an intellectual disability. So let me address both of those. So as I said, epilepsy occurs at a much higher rate in association with dementia with people with Down syndrome. And in fact, that's one of the things that increasingly we encourage, that if someone has a late onset seizure, that as well as treating the seizure, that we advise healthcare professionals that they should also be scheduling the person for assessment for dementia if it has not occurred before. It's pretty, the link is really strong. Some work that I've done with colleagues, we have it's actually a population of 80 women with Down syndrome that we followed now for a little over 20 years, and it's almost 100%. So it's definitely something, and it's many times it manifests in falls, and so we really encourage people to be sort of observant for that. And the thing is that the epilepsy can often be treated, so that we see the co-occurrences of epilepsy, meaning that people then have even less opportunities for independence. And so we really argue for active management of epilepsy. In terms of examples of an intellectual disability, I think that there are several, the term, well, we've gone through a lot of terms. We started out in the beginning of the 20th century, we talked about feeble-mindedness. Then we talked about mental retardation. Then we recognized that there were people who had similar kinds of disabilities that were cognitively related, but didn't fit the traditional description of mental retardation. And so then we developed the term developmental disabilities. But part of what happens is that terms evolve, and also this is also a global phenomenon, and people are using different terms. So the term intellectual disability has become much more prevalent internationally. But when I think about intellectual disability, it's similar to what we used to call mental retardation, in that it's about an onset prior to age 18. And we've been moving away from all of that more towards looking at sort of what the functional meaning is, and also recognizing that people, with other types of disabilities have similar kinds of needs. So certainly when we look at developmental disability, we're also including things like cerebral palsy. We're looking at traumatic brain injuries if they occur before age 22, things like that. But it really is but I think the aspects of it is that it's lifelong, and that it affects both our function, but also our ability to think, to manage ourselves. And so it's why then sort of a relatively small additional change because of dementia has a big impact upon independence. Someone asked about autism. They mentioned specifically Asperger's and what's their prospect regarding Alzheimer's and dementia. So the challenge with autism is that autism, in terms of its use, is relatively recent. So, for example, I can think back. I was a provider in the early 1980s, and I started seeing people being referred to me with diagnoses of autism, but they tended to be people with significant functional limitations or intellectual limitations. People with Asperger's would not have been referred to me at that time. And so we've not really followed them for as long a period of time. I firmly believe that there are people with autism who are now manifesting as having dementia, but they probably weren't diagnosed as having autism in their early years. They were more likely to have been diagnosed, for example, with severe mental retardation. So we're just beginning to explore all of this. And there are several people who are now tracking populations of people with autism. There are indications that there is earlier onset in people with autism. There are also indications that the symptoms are being interpreted as behavioral symptoms rather than symptoms of dementia, which is actually similar to what has happened for many people with an other intellectual and developmental disabilities. I don't believe there's a lot of information yet on Asperger's, but there are groups that are looking at it. Someone asked about UTIs in women and dementia. I can certainly talk about that in terms of for people with an intellectual and developmental disability. Many of us, in terms of, when someone is reported as presenting with behavioral difficulties, one of the things that we always want to outrule is whether or not there's a UTI, that there's an awful lot of UTIs that are undiagnosed or underdiagnosed or undertreated. And we instead sort of look at what we see as the behavioral manifestations of that and treat those rather than looking for the UTI. I think that's probably true in the general population as well. But I know that it's well documented in people with an intellectual and developmental disability. Someone asked, is there special caregiving issues that we need to know about due to COVID? There's a lot of work going on at the moment looking at COVID in this population. And we really don't have all of the answers yet. We do know that people are, I think that what has protected a lot of these family caregiving situations is precisely because the caregivers themselves are older. And so they were more likely to cocoon, to sort of not engage very much, certainly during the first 6 months of COVID. They stayed inside, they stayed separated. I think, like everyone, people are feeling trapped inside. People are feeling that they gotta do things. But I think that there's the intellectual disability services themselves have worked very hard. But I think that it's the same issue that we see with other vulnerable populations. If you're vulnerable, you are more at risk. And if you're vulnerable, it's more likely that COVID symptoms are much worse and have poorer outcomes. And so I think that the issues, I think, are much more about, think of this as a vulnerable population, do what you're doing for vulnerable populations. I got a couple of more questions. Is there a resource that lists the number of people with intellectual disabilities, developmental disabilities, and Down syndrome? There's not a, well, there are statistics that are put out by the Centers for Disease Control, and you can find those on their website. There are also studies that have been put out that calculate the numbers. The problem really is that we are reliant upon reports of these disabilities rather than necessarily that everybody has been tested. So there's some disagreement between groups. The National Down Syndrome Society, if you go to their website, you'll get a lot of really good information about people with Down syndrome. There's a report of the states that's put out by David Braddock and some other people. So if you Google David Braddock and State of the States, that'll give you a lot of information about people with developmental disabilities. Are there any permanent supportive housing facilities available for those with intellectual and developmental disabilities? There actually are a lot of housing options. Those are frequently listed by state. I think that go to your, the relevant state agency is called something different, it feels like, in every state. But if you, I think putting in developmental disabilities will probably get you the easiest access to what your state resource is. You'll find out, what the types of housing are that are supported. And then you can also look at then sort of who the providers are, what's the process for being declared eligible. Someone asked, should Alzheimer's be considered a disability? Wow, that's I think that's an issue that goes beyond me, because clearly, you know, that speaks to what services that people are potentially eligible for and other kinds of assistance that people are eligible for. But I think that, you know, in some ways I think about it in the same way that I think about the definition for developmental disabilities. We are much more interested in sort of what this means functionally for people, what this means for the independence in their lives. And clearly, as Alzheimer's advances, people's functioning is impaired. People's ability to lead independent lives is impaired. And we should be looking at sort of what are the services that we can provide, so that people are able to maintain independence for as long as possible, but how will we support the supports that they are going to need? I think right now we are very reliant upon the interventions for caregivers to be an important part of this. I think that much of what we do in terms of services directly for people themselves are much more around assessment and around planning and around respite. But respite, I always think of as a service that's for both of us. It's for the person with dementia and it's for the caregiver. And I think that that's likely to be how services are provided going forward. But I think that you know, the various advocacy groups need to work on, first of all, whether they want to pursue Alzheimer's being considered a disability, and then what that means and how that might be achieved. And I think I've covered all the questions that I have, but we still have a couple of minutes yet. So if somebody wants to quickly put something either in the Q&A or in the chat, I'm happy to respond. Not seeing any other questions. Sari, I'll pass it back to you.
Great. Thank you so much for this excellent presentation and for sharing your insight and information with everyone who attended today. We appreciate all the participants, and we're excited to get this recording all set up for others to utilize it in the future. I do think that Sarah just wants to announce the post-training evaluation link is in the chat. Phil, I don't know if Sarah is unmuted, but you could.
She is, yeah.
Great.
I think I am, yes. So if you have some time to do it right now, that would be wonderful. I think we'll also email out the post evaluation link since we have your emails from earlier. And then that way, if you don't have time right this minute, that's okay. Although it is very short, and while it's nice and fresh in your head, I would urge you to complete it right now if you possibly can. Thank you very much.
Great. Thanks, Sarah. Phil, I'll turn it back to you for any final comments, but thank you again, everyone, for attending today. And thank you, Dr. McCallion, for your excellent presentation.
Thank you. And I just want to thank the National Alzheimer's and Dementia Resource Center and grantees all across the country who are really making a difference for people with Alzheimer's disease and other dementias, and in particular for people with intellectual and developmental disabilities. This is probably one of the most important programs for raising awareness about these individuals and their family caregivers and offering supports. And I also want to thank the Administration on Community Living, whose grants program this is, and who has always been interested in reaching vulnerable and health disparity populations who are experiencing Alzheimer's disease and other dementias. I will hold this open for a couple of minutes so that people can complete their post-test. And I want to thank each of you for participating today. And as Sari said, we will get this recording out with as closed caption and with a transcript. Thank you. Okay, I'm going to close down the webinar. Thank you all again.